So what are some of the best case studies of technology adoption across Jefferson that you've witnessed?
Oh, with Jefferson, and they've always been clinically excellent. Like they've gone the next level and they're advancing it. And we also have a AI center of excellence now where we're looking at all of the avenues of ways that we can better integrate care in the physician practices, in the ambulatory setting, and in the inpatient setting. We've got ability to do test runs on virtual care with our nursing teams and collaborate that across the region, pulling out the best practices. So we're only investing and making the investment in the things that are actually working. And so the ability to pilot, pivot, and learn new things, we've got those running in all lanes on the physician practice side, the research side, nursing, and supply chain. We really are covering a lot of ground.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
Okay, I am joined by Dixie James, the president of the Central Region of the Thomas Jefferson University Hospital System. Dixie, welcome.
Thank you. Thank you for having me. Excited to be here.
Our pleasure. So I don't know whether you've had a chance to listen to any Analyzing Healthcare prior recordings, podcast recordings, but what we like to do here is get stuck in to this meaty thing called healthcare. If healthcare was a food, it would be a big steak or a burger. It definitely wouldn't be some corn. Am I right in saying that?
Absolutely right. I've spent over 25 years in healthcare, my entire career, and I couldn't agree more.
There's just so much going on, and you're a perfect example of that, because when I look at your resume, as is often the case when I have a podcast guest, I'm just overwhelmed in imagination, just thinking about all the different challenges that you've had to face to get to today. And this today is probably filled with a whole slew of new challenges. So it's just a constant wave of opportunities to create value, to make a difference, to influence outcome for the benefit of patients. So just, it's always a sense of awe to be in front of someone that's covered so much ground, so much terrain. I'm going to jump in with questions. Thomas Jefferson, 32 hospital campuses, 65,000 employees, 100 sites of care, plus its own health plan, the Jefferson Health Plan. Is that a fair overview?
That's us. That's Jefferson.
So it doesn't lack for scale and size. Einstein, where you were for quite some time as the president and CEO of the Philadelphia Hospital, one of 3 hospitals that they had, probably, I would guess, their largest. Also meaty, but smaller in comparison. I would say about 1/10 of the size of Thomas Jefferson. Fair contrast?
Fair contrast. I mean, Jefferson Health today is grown tremendously in scale. At the time of the merger, we were more life size at the start, but we have grown tremendously. And so currently, if we were independent today, we would be a small portion of that piece that you just described.
Okay. So not every day. We are increasingly speaking with health system CEOs, C-suite CEOs, presidents, which I absolutely love, because only covering everything else in healthcare without that critical piece is like sitting on a stool that only has 2 legs as opposed to 3. So welcome. It's always a pleasure to have health system voices here because they're critical, foundational. But even better than that, a health system leader who has led a smaller system merging into a larger system, which I think is really unique and interesting to listen to. This merger, I think the conversation started, don't hold me to this, but around 2015, 16, and only finalized, closed late 2021. So it took a while. It had many roadblocks, obstacles. The AG in Pennsylvania initially opposed the deal. So there was plenty of machinations just to get it done. Do you want to walk us through what that 5-year period of maybe we're merging, maybe we're not, what was that like? Is it something that just existed in the background, or did it impact and influence your way of thinking and your decision making?
Great question. And it impacted everything, right? And so you talk about that 5-year period of time, and it encompassed so much, but it still stayed at the forefront. So we had COVID during that time frame, and we talked about the AG's opposition, but we also had an FTC challenge. Lots of excitement initially, obviously, when we started down the path, but that waned a little bit, and then we had COVID, and then folks were trying to recover from that, and we were going through challenges. So we always knew it was strategically important for Jefferson, now Jefferson Einstein Philadelphia, and really the Einstein Healthcare Network at the time, to partner with and align with a larger system. The campus that I oversaw, and it included Elkins Park and the rehab attributes. We were primarily a safety net hospital with that mission. That is, as you know, because you understand healthcare, that is an unsustainable mission without scale and access to capital to reinvest in our infrastructure, our technology, and our people. So it was too huge to not think about, although we did have some major things that occurred during that time. But we always at the forefront was an eye to the future, making sure that Einstein at the time, 150 years in that community, was going to be able to be an access point for another 150 years. And we knew to do that, to ensure that we needed to keep our eyes strategically on the right partner.
So the FTC and the AG initially opposed. My guess is they probably used the word monopoly to try to justify the opposition. Let's try to examine that viewpoint in retrospect. So now we're 5 to 10 years after any opposition to this merger. Wasn't any of it valid? And I know the bias is to say, of course not, this has been the greatest thing ever. But let's imagine this isn't being recorded and you can just speak objectively about the good and the bad. There is this knee-jerk reaction that 1 in 1 hospitals equals 1.5, but not 2, because society loses in things like fair competition. But I asked the question aware of the counter argument, because it's in our company name, right? We're called Scale. And the benefits of scaling are, in my opinion, tremendous in healthcare, especially in healthcare where everything operationally is so hard. So given all of that, was the FTC right in any way to try to block this transaction? What did they get horribly wrong? What did they get right?
So, I will say that bias, but I will also say that what I led with is that we were a safety net hospital looking to continue to deliver care in a community that was going to be unsustainable. 85 to 90% government payer mix. So anyone that understands the industry knows that is not a sustainable mix of payers to maintain services. And so we were faced with, at some endpoint, not being able to deliver care. So it's really important when I think about what the FTC was looking at and creating monopolies. How do we balance what we were trying to accomplish? And, I think that there's plenty of competition in the Philadelphia market. It's rich with eds and meds. We have tons of other hospitals. So the idea that somehow we were going to not be able to give care to emerging or do less for the community. So that's where they got it wrong. I think the goal of the merger, to do more and to be sustainable in the community. And as a matter of fact, Jefferson's pole position really is the most accessible healthcare system even now. And we've been a part of how they've advanced that goal. And so the intent was always for good and to not reduce access. And I think the FTC saw it in a traditional competitive way. But we knew that in the market, there was already a tremendous number of other systems that would always keep us very competitive. And I think that's why the local support court system did not upheld the FTC ruling, because they understood the more nuanced nature of our local market.
So we see this regularly as we spend more and more time with health system leadership, that safety net is expensive and requires funding. It doesn't fund itself, being available to anyone and everyone for anything and everything. And so you do need a system that can generate funding through profitable endeavors, a commercial payer mix, diagnostics, surgery centers, the things that high acuity procedures in large numbers, the things that really drive profit and through profit funding. And then the large endowment and the large donations, the contributions, the interesting programs that health systems participate in. So all of this speaks to scale. Are there things that Einstein brought to Jefferson that has changed the way that Jefferson looks at the world? Because Einstein had a really unique reputation, very local, culture-driven, service-orientated, flexible, flat hierarchy, everything that a large system isn't. I would imagine a pretty fun place. to grow up in? Are there things that Einstein has been able to influence a huge national system in the way that it views the world?
Great question. Yes, and you touched on some of them in that I think we being the group of people that were there for the community, we had very strong community relationships, very deep roots, and I think that support lends a bit of trust when you're looking at them trying to do things locally. Lots of strong relationships. It was a fun place to grow up because it was like family. Everyone was there working very hard. We all wore many hats. So I feel like I used to joke that your experience that I had with 12 years, 7, because you were doing so many things, and everybody was there with the mission in mind, and knowing that we had to go above and beyond to get it done. And we had to figure out a way to do more with less. And we were very nimble and we moved very quickly and we took very data-driven approach to risk taking because we didn't have a lot of margin or room for error. So there was a lot of discipline, financial discipline, a lot of operational discipline. And so between that and the community and a culture really that is very family-like, I think those were attributes that we were able to bring over as we now develop a broader culture at Jefferson, that all the individuals, that still honors the uniqueness of all of our hospitals, but brings together one singular combined culture.
And how has your role changed as you joined Jefferson? You've been given more than one hospital location. I know your budget now is north of $3 billion. Just walk me through, what are your responsibilities like today? How do they compare?
Yeah, well, I will start by saying that, upon joining Jefferson, I've had a couple of roles now. I started off, I have a background in strategy as well as operations. So one of the first additional enterprise roles I took on when we merged with Jefferson was really service lines, managing the service lines for the enterprise, which at the time was 17 hospitals, and looked at standing those up and the growth programs for those service lines. And then when our CEO, Joe Pichon, joined us, he reorganized the markets and realigned my market, which had Jefferson Einstein Philadelphia. And again, I already had Jefferson Moss McGee and the ambulatory components associated with that, and then added to that a central region, which then allowed me to pick up Thomas Jefferson University Hospital, Jefferson Hospital for the Neurosciences, and Methodist Hospital. And those were downtown in sort of the academic for Jefferson. And I also picked up McGee because I had the rehab on Moss side. So in sum total, those hospitals and the hospital-related ambulatory components are what's under my purview. So it's been a journey from doing some of the service line growth and thinking about how do we, as an enterprise, position ourselves to meet the need of our communities in those areas, what type of technology, what type of investments. How do we position ourselves ambulatory versus inpatient? But then pivoting back to day-to-day operations and overseeing the success of this region to make sure that we're integrating and that we're talking to each other and that we're not competing internally, but we're building culture that's going to drive excellence.
Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire lifecycle. Denial Shield proactively prevents denials before claims ever go out, using agentic AI to automate root cause detection and resolution. Front Desk Shield streamlines preclinical and front-end workflows, eligibility, authorization, and intake, reducing friction before revenue is even created. And Revenue Shield maximizes charge capture and revenue integrity, ensuring nothing slips through the cracks. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scalehealthcare.com and see how the Shield suite is redefining AI-powered us.
So given all that broader experience and given your exposure to Jefferson, 60 plus hospitals, how many states?
We are Jersey and Pennsylvania.
2 states, very concentrated footprint, your own, it was just pretty good. You must have a lot of control over patient behavior, patient demographic. Within that concentrated space, you can really create a curated program for those patients, soup to nuts, continuous care, oversight. So I'll get into value-based care in a second. Also curious that you run your own payer program, the Jefferson payer program. But leaving that aside, your expanded vantage point, which is near and dear to my heart. I took a business that was largest in the state and merged it with a business that was the largest of its kind in the country. And one of the primary reasons why I did that is I had a lot of questions that didn't have answers. And I thought that a much larger footprint could give me operational answers to those questions, like what to centralize across what states, and do these centralized functions work at scale? Extra resources, does it yield better results, or does it yield more complexity? So given everything that you've learned, if you could take a time machine back to Einstein and say, hey guys, I've just learned the following, let's change A, B, and C. What would you report back? What would you change in Einstein in 2015?
To 15, oh, 15, I thought you meant post-merger. If I had to go back to 15, what would I change? I think I would be making, to the degree we could financially, I would be making more investments from a technology and infrastructure perspective. I think that is the area that, we're now seeing the ability to do so much more through automation on really to focus in on where that can change our future trajectory. I don't think we had it on our radar at all, quite honestly. We were dabbling in some of the AI stuff for our radiology and some of our readings, but hadn't really strategically thought about the leverage we could have and what we could do if we were to position ourselves around costs in some of the areas that we could save if we're doing more with AI. So I would definitely think about our technology footprint and where we made investments.
So a large system like Jefferson finds the time, the resources to really dig deep into technology. So what are some of the best case studies of technology adoption across Jefferson that you've witnessed?
We've got a panacea that there's a lot of work going on both on the university side, and we have the benefit of that. That's something that at Einstein we really didn't tap into or couldn't tap into as much. We had an innovation center in joining Jefferson that we did not experience. We had a university at a real research infrastructure that was looking at not just cutting edge technology that helps us on the operational side, but clinical care delivery and what are the latest advancements in how we treat cancer patients. And we're now a comprehensive cancer center designated by NCI, and being at Einstein, we now have access to that research, to that insight, to those protocols. Those are the types of things that we couldn't foresee. But now with Jefferson and they've always been clinically excellent. Like we've had a neuroscience institute, but they've gone the next level and they're advancing it. And we also have a AI center of excellence now where we're looking at all of the avenues of ways that we can better integrate care in the physician practices, in the ambulatory setting, and in the inpatient setting. We've got ability to do test runs on virtual care with our nursing teams and collaborate that across the region, pulling out the best practices. So we're only investing and making the investment in the things that are actually working. And so the ability to pilot, pivot, and learn new things, we've got those running in all lanes on the physician practice side, the research side, nursing, and supply chain. We really are covering a lot of ground. And that is the ability of the importance of scale, right? That is not something that we'd have the ability to invest in as a single or three hospital system, with one of that being just a major safety net hospital.
So as you observe other smaller hospital systems or hospitals merging with large national systems, when you see HCA or Trinity or United or Ascension or Advocate pick up more hospitals, are you thinking, wow, that's going to be a merger nightmare because you've lived through the merger and it's brutal and it takes forever? Are you thinking, of course they're buying more because the smaller system is going to be a safety net system and it's going to need access to a lot more funding? Are you thinking, well, that group's really going to enjoy access to the academic infrastructure that larger system probably provides? They're going to have access to better technology. What goes through your mind when you see those mergers? Because I can tell you the average journalist, the average skeptical politician, right? And probably as a result, the average citizen is thinking, well, here comes another monopolistic power play with more price manipulation to boot. And I would suspect they've probably got it wrong, right? There is plenty of that. We see hospital price inflation on an annual basis is high. We have not bent the curve in that category yet. So there is a lot of validity to it, but then there's all the other benefits that you're near and due to. So what goes through your mind when you see others doing the same thing?
Of benefits. So I think that having been on the side of both sides of the merger, been on the side of the small health system merging into the bigger system, and been on the side of now the larger system merging another system with our recent acquisition and merger with Lehigh Valley Health Network. So I've seen it. I can understand the difference in being on the receiving end and being on the merging end. And I can tell you that there is a sense of all employees, there's a sense of trepidation that folks are going to feel. And if you do it right, though, there's also lots of rewards and value, not just on the bottom line, which is obviously top of mind for our boards, but really for the employees and for the patients. And I think when we lead our integration strategies, when I hear about mergers, they talk about mergers, I look at the dynamics and I say, wow, but there are really good synergistic opportunities to increase access for patients and to potentially save care in their communities. I know that that's going to deliver value. And even if the change process is challenging, that they're going to ultimately benefit from that. And that's the true driver. I also think about when I hear those stories is we have a benefit of being a regional system. You touched on it a little while ago. Because we're not a health system picking up a hospital, somewhere in New Mexico. And I'm not saying that we couldn't run one. I'm sure we could, but there's value to being able to streamline care and to really get the best synergy across the region and how we distribute services and redirect. I mean, I think that's something that can only be accomplished with a large regional system. And so with other systems, I listen for how are they going to leverage this in a way that's really going to deliver value back to the patients and really deliver value back to the staff. Because one of the most important things you have to do in these integration processes, make sure that the staff is fully engaged and that they feel and see the value of the merger, so that if they're not engaged and you have so that story integration efforts are probably dead on arrival. So, understanding the why and really making sure that the team is bought into it is what I listen for, because it isn't just for the people living it. People at healthcare tend to be people who want to deliver value. They want to serve. And so for them, it has to come back to a core mission or a core value. And so I listen to whether those mergers are going to deliver on any of those core pieces.
Yeah, the contiguous, concentrated regional footprint lends itself to turnkey solutions for any given patient, soup to nuts, upstream, downstream, right? So you've probably solved from primary care all the way down through diagnostics, high acuity, continuous care, home care, post-acute care. You've probably solved for all those pieces. And I'm guessing I should be asking the question versus making the statement. You don't think in terms of episodic patients, you think in terms of Jefferson patients. Right, these patients their lives in total are of keen interest to you, and that probably opens the door to community activism, preventative care. So I'm curious. Let me invert all of that into a question. Are you thinking in those terms, and what are you able to do, Dixie, with a Pennsylvania, New Jersey patient that you wouldn't be able to do for an Arizona patient? You picked up Arizona patients tomorrow.
It really depends on the service. So I will tell you that if I'll take one of our major service lines and say cardiac care. So if I am delivering cardiac care to a patient who is from Arizona, what I can offer them is clinical expertise in their surgical procedures. Absolutely. The physicians that we have here are best in class. And so they're going to receive cutting edge care. What I can offer them that I can offer someone regionally is that coordinated post-acute care and follow-up care with Jefferson physicians that are going to be coordinated and aligned with their surgeon, and that they're going to be followed by, and then the downstream testing and all the other pieces coordinated and packaged in a way that makes for seamless care. And then makes it easier for our patients to recover. And I can offer them access points that are closer to their home and their families so that they can also find themselves better supported. I can offer them community resources that we may not provide, that we coordinate with, that would create for, again, a better continuum and seamless care provided for them. Whereas my Arizona patient is going to get the inpatient clinical surgery care by an excellent surgeon, and it's going to have a wonderful outcome. And then all of that follow-up and care coordination is going to have to be done by another provider. That creates disconnects.
Yeah, it's interesting as I'm listening to you describe that, I'm thinking that we're missing certain terms in healthcare. For example, we use the term coordinated care, but we should be using the term uncoordinated care a great deal as well, because there's a lot of it. It's everywhere, and it makes a huge difference. And what we don't do by not using is we don't give credit enough to groups that are providing and solving for coordinated care. because we just don't point at uncoordinated care and say, there it is, that's uncoordinated. So I just kudos to the Jefferson system and to the Einstein system for recognizing that, prioritizing it, because I know it benefits patients a great deal. Let's talk about how that flows into the Jefferson Health Plan. Is the Jefferson Health Plan working? Is it growing? Is it everything that everyone hoped it would be? Where do things stand there? Because I know other groups like Northwell ignominiously attempted a health plan and then backed away from it. So it really does vary.
Well, I'm going to talk about the health plan, but I'm going to leave room for, the health plan is evolving, and we've got a fabulous new president of our health plan who's got new visions for where we need to go from a health plan perspective. But I will tell you, just by history, the health plan has been acquired, or historically a Medicaid plan that Einstein owned a portion of, other health systems owned a portion of, and Jefferson ultimately now owns totally. And I think that the hallmarks of that plan is that it's always been very community focused and very community integrated. So again, focus on the Medicaid population. And I think we're now branching off into new products. So is it performing? I think from a value-based and population health management perspective, I think plans in general struggled last year. Prior to that, performance has been extremely strong. But I think many payers struggled, and I think we were no different. That said, I think where we are positioned strategically and the product lines we want to develop and the areas that we want to expand from a plan perspective align with our health system goals, which is what's really amazing about, I think, the way that Jefferson has structured and works to their benefit. We've got the health plan, we've got the health system, which is the 32 hospitals, and we've got the university. And we're using that to support the work that we're delivering to our patients and communities. The health plan's agenda directly aligns with how we know where we know we need to do better for our patients and what type of services we need to funnel for our patients. So we're helping inform that development. And strategically, I think there's a lot of opportunity. So we're excited about, again, where our new leader is thinking about taking us. And so I think everyone believes it's performing well, but it's got better and brighter days ahead.
Yeah, no, as I just quickly chat GPT it, it's definitely expensive. It's a $196 million loss for 2025, the health plan, or 170 if it was the health plans. It's quite an investment, I would say, at this point. So it's going to be interesting.
Just touch on that, because I will say that, in defense of the health plan, that there was a lot of that was triggered by a GLP.
Yeah, it's interesting that comes up. That's a lot of GLP-1 usage. There must be a lot of very thin people running around Pennsylvania.
Well, there was a decision around criteria, and that made it accessible to everyone. And so, whether clinically learning curve.
Learning curve.
And then there were some rate issues. But, that said, I don't view that as the run rate or trajectory for the health plan's potential. I think it is uniquely positioned to grow and add tremendous value to us. You talked about that three-legged stool. I think that's an important part of it.
Yeah, I mean, it's an investment experiment that a large system gets to do, and a small system would struggle. So it's another perfect example. It's never a straight line when it comes to launching these initiatives. A couple of questions. Lehigh, that integration, how did it compare to the Einstein integration?
I like to say that we got it right with the Lehigh integration and lessons learned from the potential missteps out of Einstein. I think, Einstein, we were coming out of a pandemic. We were still recovering. We were going through FTC trials, and then we merged, and we rushed into the work that needed to be done. And I think that there was opportunity to do more around change management and preparing our teams for the tools and the support needed to really have a successful integration. I think some of that was bypassed. And I think we suffered the consequences of that in some cases. And I think for the Lehigh Valley merger, the time and the leadership, we really thought through how to welcome in and how to create the structure and the support system to make that merger successful. And I think that's been all the difference.
My experience of integration is that it really is a muscle, or it's like playing tennis. The more you do it, the better you get at it. So that's not a surprise to me that the second integration went better than the first. Last question for you, and I want to also say thank you for your time, because it's really gracious of you and generous of you to spend the time to help our audience understand the world from the lens of health system senior leadership. It shouldn't be a black box mystery, and we're hopefully together helping to alleviate some of that, take the stress out of it. So the last question is Highmark. So I know Sarab, who's moved on to Ascension. I had the chance to interview him back in the day when he was a little bit just after Highmark. And they focused on Pennsylvania, they focused on New Jersey, and they like to think of themselves as the big dog in the marketplace. Are they? How does Jefferson think of Highmark? What are the differences, the similarities? Do you even think about?
I mean, I think you have to think about Highmark and all the big players in the market. I think there is a desire. I think the similarities is there's a desire to do better with the patient health and the health of our population. And I think Jefferson views Highmark as a potential place that we can talk about opportunities to do that. But I think we're doing that with all our payers in the market because we recognize that we're not competing against each other. If we're ultimately going to bend the cost curve and we're going to do that together, right? We're going to have to figure out ways to better align, to talk through the similar concerns that we have with different approaches we've been taking and what can we do differently. So I think that Highmark is incredibly important to the conversation because they are, just look at the market share. And I think that's enough to say that they're a big player and they have the opportunity to help sway the health of Pennsylvania. And I think they want to be a part of that. At least that's the impression that I've gotten. And I know Jefferson, we are fully committed to the health of the regions that we serve. And that is why everyone gets up every day and works the hours that we work. Many of us, this is a 24/7 gig. Whenever there's need, we're there. And we do that because we're fully committed to what we do and why we do it. Healthcare is, everyone comes this way one way or the other at some point in their life. And whether it's you, it's your family, it's a friend, it is very emotional. And I know that we think about that in how we deliver care and how we develop solutions. And so any partner that's as passionate as we are looking to align with them. And they have to be out of industry, in different segments of our industry. We're not going to discriminate. We're really going to passionately pursue getting answers and making advancements so that we can deliver care well to our community.
So you think of them as a payer, despite the fact that they have that Allegheny Health Network, those 14 hospitals.
No, I don't think that they're a large integrated system, but so it's not just that. That is certainly some of their more recent years, their entry points have been more on the payer side, not necessarily on the health system side, but they're large enough to be doing other things for sure.
That's interesting. And I think Kaiser as well, they bought Geisinger. Kaiser also moves into that same region as a fully integrated payer plus provider and sort of asks the question, are you going to think of us? Are you, Jefferson, going to think of us as a payer, or are you going to think of us as a hospital competitor? And it sounds like there's an opportunity to think about these groups from two different perspectives. On the one hand, competitor, on the other hand, payer. And United's been doing that forever, for a long time, across multiple states.
A third lane would be payer, but it could also be partner,
I thought you were going to say that. Yeah. Okay, so that's healthy. Any questions I should have asked? What have I left?
First of all, this has been a wonderful opportunity to just share insights into what's one of the hardest things I think you have to do in healthcare, which is integration work. I think the only thing I would share beyond what you've asked me is just touching again upon the importance of the people and integration. I mean, this is really moving people's cheese and then asking them to come along with you and to believe in what you're doing.
I love that cheese analogy. It really, really nails it. People are very passionate and possessive about cheese for some reason.
And these are a bunch of type A individuals that are trying to do the right thing, committed to best practices. And we're saying, yeah, we think we think you got it right, but we want to do something else. And it's really hard work. Consolidating programs. I had to close an emergency department, which was a very
that sounds brutal,
emotionally driven process. But then getting your team
that's definitely not on my bucket list.
I hope I never have to be in that seat again. I have some great lessons, and I think we pulled it off as best as possible. But I will tell you, it's hard work, and we couldn't have done it without the trust of our teams, putting them first, listening to them, collaborating with them, and talking to them. Transparency around the why we're getting this done, and so that they can see and believe and have trust in the outcome that we're going to have on the other side of it that makes it worth the work to get there. So I'll just add that, and that's been a huge learning point for me. And one of the most rewarding things about the integration work, outside of seeing the outcomes, is really getting the teams aligned and seeing how valuable it is when you have their buy-in.
Dixie, listening to you for this past 45 minutes, hour. I'm not surprised that you've been given the leadership roles that you have over the years. And I think, honestly, it's just the beginning. And I'm looking forward to the next 20 years, the next 40 years to see where this journey takes you with real anticipation and excitement for you. So thank you again for spending the time with us. And hopefully this is just the beginning of you and Scale Community spending some time together.
Hope to see more of you. This has been wonderful. Thank you again.
You got it.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.